Okay. So I want to say thank you first on behalf of myself and Susan Block and Atul Gawande and the rest of our team at Ariadne Labs for having us here to speak with you about this topic, which we believe is critically important. I find this topic compelling not only because of the work that I'm going to present to you, but also because as a field, we continue to grapple with trying to improve comprehension of what we do, of what palliative care actually means, and of who is to benefit. And I think this is a health literacy issue that, as we have heard, is one as acute for physicians and other clinicians as it is for patients. I also have no disclosures. So my objectives over the course of this presentation are to introduce you to a scalable primary palliative care intervention to improve interpersonal communication between clinicians, that is doctors, nurses, physician assistants, social workers, and their seriously ill patients. By primary palliative care, I mean the basic palliative care skills that clinicians who work with seriously ill patients should have, including oncologists. Next, I will discuss the connection between health literacy, a communication intervention like the Serious Illness Care Program, and access to palliative care. And finally, I hope to describe a process of adaptation by which we are actively addressing issues of health literacy in diverse populations. So I want to start with some definitions to lay the boundaries for the concepts I'll be addressing. The definition I will use for health literacy is expansive. The Prescription to End Confusion report from this institute defined health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. It then went on to describe health literacy as an emergent phenomenon, when expectations, preferences, and skills of individuals seeking health information meet the expectations, preferences, and skills of those providing information and services. That is, health literacy is not something possessed, but something that emerges from the interaction between a clinician and a patient. Furthermore, health literacy is sensitive to the demand it places on one to decode, interpret, and assimilate health messages, and is therefore dynamic and situation dependent. And I'll discuss this more in depth in a few minutes. Similarly, when I discuss palliative care, I'll be referring to a set of services concerned with patients in all phases of serious illness, which is to say an illness which places a person at high risk of incapacity or dying within a certain time frame. Again, it is a health literacy problem that has physicians continuing to believe that palliative care only has a role at the end of life. So the Serious Illness Care Program has developed a systematic and systems-level approach that we believe addresses two fundamental gaps in the care of seriously ill patients and their families. The first is the gap between what we want for care in the setting of serious illness and the care that we receive. Most Americans, including those of all colors and creeds, wish to spend their final days at home and want less aggressive and more symptom-focused care, especially when they are aware of a terminal diagnosis. They do not want their dying prolonged, they wish to achieve a sense of control, and they want not to burden their family and friends. What we get looks somewhat different. A majority of Americans die in institutions, non-beneficial aggressive care is common, and while hospice rates are going up, length of stay is going down, and transitions in the last 3 days of life are increasing. Among the consequences of this are inadequate symptom control and worse quality of life for patients and their caregivers. The second gap is that between what we know and what we do. And to be more specific, we know that discussions to clarify goals, values, and priorities for care, what can be called advanced care planning discussions, are associated with improved clinical outcomes, including more goal-concordant care, less aggressive care, more and earlier hospice care, and higher patient satisfaction and family well-being. Furthermore, patients do not appear to be harmed by these discussions. That is, they are no more anxious or depressed and feel no loss of hope when they have them. We also know, incidentally, that there's a connection between clinician burnout and poor self-efficacy in caring for patients with serious illness, and that clinicians feel closer to patients and feel better about the care they provide when they speak earlier and often with their seriously ill patients about their goals and priorities. Of course, people with serious illness want not to focus on dying, but rather on living as well as possible for as long as possible. Early conversations about goals and priorities enhance a patient's sense of control, providing space for planning and closure, and focuses patients and families on what matters most. Thus, communication has implications not just for how they die, but also how they live. What we do does not reflect this knowledge. Put simply, we have these conversations too infrequently, too late in the course of illness, and we're not that good at them. Or as I say, too little, too late, and not great. This is particularly true for communities who suffer disproportionately from poor health literacy. So the Serious Illness Care Program is a systems-level intervention designed to address these gaps. It involves a process of identifying seriously ill patients, training clinicians in the use of a structured conversation guide, preparing patients to participate in these conversations, prompting the clinician to have these discussions, having the discussion, documenting the discussion in a single, easily locatable place in the EMR, and providing materials to the patient to carry on the conversation with their family members. The heart of this process is the Serious Illness Conversation Guide, and it, along with other relevant documents which I have provided in advance to you, are most relevant to a discussion about health literacy. So that we're on the same page, the questions are as follows. What is your understanding of where you are now with your illness? How much information about what is likely to be ahead would you like from me? We encourage clinicians to share the prognosis. If your health situation worsens, what are your most important goals? What are your biggest fears and worries about the future with your health? What abilities are so critical to your life that you can't imagine living without them? If you become sicker, how much would you be willing to go through for the possibility of gaining more time? And how much does your family know about your priorities and wishes? Now that I've described to you our intervention, the dissemination of which I can answer questions about later and adaptations of which I'll discuss in a moment, I want to move to the second objective, which is to discuss the relationship between health literacy, communication, and access to palliative care. In keeping with the spirit of our guide, I'm not going to talk about how we get people to understand what palliative care is, but rather how to help clinicians open a space through conversation that helps patients both maintain hope and hold in mind the possibility of dying. But before, and by contrast, I'd like to highlight an intervention which I feel is less likely to open this space in a sustainable way. That is the POLST paradigm of advanced directives. POLST, MOLST, POST, MOST, etc. are physician or medical orders for life-sustaining treatments or for, quote, scope of treatment. And all but 5 states have some version of the POLST in place. Other approaches to improve advanced care planning, such as respecting choices, focus specifically on POLST as the last step. I've come to think of the POLST paradigm as problematic for a few reasons. First, enactment of the POLST paradigm has proceeded without clear thinking about how to train clinicians to have these discussions. It seems as if the goal is to force the discussion using a tool to clarify procedural options for care. Thus, it seems to me to put the cart before the horse. The horse in this case would be the goals and priorities that inform people's ideas about what kind of care they want. Second, the cart in my analogy has its own problems. Advanced directives are a contested strategy for delivering goal-concordant care. Consistent evidence in the literature demonstrates their lack of efficacy in this regard. As many clinicians know, there is not infrequently a family member waiting in the wings to reverse any given order. Also, patients undergo a response shift in response to serious illness that may impact their thinking in ways that a POLST form may not reflect. Third, the menu that the POLST offers may as well be written in a foreign language. These are not interventions with which most people have familiarity and will have had meaningful experiences. They do not know the impact of these treatments, their risks, and their benefits. And even if they did, how do we know that the ways we are explaining them facilitates the kind of comprehension that leaves people feeling confident in their decisions? As we heard earlier, I think we don't understand that. And this is a health literacy issue. Keeping in mind the definition of health literacy that I began with, I want to think about this emergent phenomenon and how health literacy emerges in such a way that behaviors are affected, both those of the patient and those of the physician. I want to introduce a factor that complicates the interaction between a patient and a clinician. What we are talking about for advanced care planning is using the right words to achieve a desired outcome, let's say the expression of goals and priorities, in such a way that impacts current or future decision making. There are many ways to say the same thing, but how something is said and how it is heard is determined by a host of power dynamics, negotiated at the point of interaction based on the historical, social, and cultural factors brought to bear in an interaction between two people of different backgrounds. This is relevant to the topic at hand because if health literacy is an emergent phenomenon, then we must be acutely sensitive to the power dynamics that exist in discussions that might open that space for palliative care to take place. The biggest one, of course, is the power dynamic of a patient with serious illness and their clinician, or their insurer, or their health system, who has the capacity to treat by curing or holding at bay their disease. We have to think about what it means when this treating clinician either allows the possibility for treatment goals to change or refers to a clinician who does that for him or her. Then there are all the factors that widen this power gap further and that are relevant to the usual thinking about health literacy. For example, education, socioeconomic position, race. And if we assume that power differentials are evident in the process of advanced care planning, then one strategy for creating safe space is to give control to the patient. We imagine doing this by preparing patients to have this discussion, by asking their permission to have it, by assessing their information preferences and honoring them, and by asking questions in ways that allow their humanity, not their illness, to come through in a way that actively shapes their care. A conversation focused on the POLST form does none of that intentionally and risks exacerbating the inherent tension in the relationship by focusing on life-sustaining procedures. With a focus on what is important to the clinicians and not to the issues of survival, suffering, quality of life, and meaning that are most important to patients and families. In the POLST paradigm and usual discussions about goals of care, we are forcing the patient and family onto our turf, into the medical model, and failing to honor the patient's experience and perspectives. So I'd like to return to race as an example as we move on to our third objective, to characterize a process of adaptation to address issues of health literacy in minority and underserved populations. The problem of obtaining goal-concordant care is particularly acute for African Americans. There are both structural and interpersonal factors that contribute to this, and a relative deficiency of advanced care planning may also play a role. We know African Americans participate in less advanced care planning than whites. The reasons for this are multifactorial and incompletely understood, but include mistrust in both clinicians and the healthcare system, decision-making informed by religious principles, family decision-making styles, and health literacy. It's hard to know the full impact of health literacy on advanced care planning, in part because health literacy is measured in studies that have examined its role in advanced care planning or end-of-life decision-making is frequently unidimensional. It reflects the way we prepare literature for comprehension in medical settings by using measures such as grade reading level. Our conversation guide, for example, is written at a 5th grade reading level. But if we think of health literacy as emerging from both the patient's experience and their interaction with the clinicians, then health literacy might be a central issue relating to achieving goal-concordant care. Before I propose that a conversation can create a space for meaningful interaction that has the ability to transform care, we're currently engaged in thinking about how to take an intervention developed in a place that serves a predominantly white, middle, and upper middle class population and understand its effect in other key US populations, especially African Americans. How do we move it out of a temple of science, let's say, onto a temple of worship? Here's a schematic that describes our approach to answering this question. We're presently in the middle of conducting a tiered set of focus groups aimed at first identifying high-risk barriers to participation in conversations such as these, and second, gaining feedback about the language and content of our serious illness conversation guide. The goal of this is to develop modifications to the conversation guide that can be implemented in populations in which certain factors that impact advanced care planning can be addressed in a culturally sensitive way. And I want to point out that we're not talking about creating a guide specifically for African Americans, which has the potential of reifying inflexible notions of culture. Rather, we're thinking about how to give guidance to clinicians about language and issues that address that allow for the creation of the safe space to which I keep referring. If these modifications are useful to African Americans, we believe they may be useful to others as well. Furthermore, the process by which we've identified these modifications is one that can be repeated. So, what have we learned so far? So by and large, the space in which goals of care are discussed with African Americans with serious illness is in the hospital in a crisis setting. These interactions are emotionally traumatic for families and add to a collective historical trauma felt acutely by members of the African American community, heightening senses of stigma and mistrust. The relationship between the patient and family and members of the clinical team, the physician chief among them, is paramount to the sense of safety for patients and families in approaching end of life. The questions in the Serious Illness Conversation Guide are easily understood, acceptable to African American participants in our focus groups, and enhance our participants' sense of feeling cared for. The addition of one question, what gives you strength and comfort as you think about the future with your illness, effectively elicits and allows for religious faith and family to enter a conversation in a way that enhances the sense of caring. So just briefly, so one patient said, I think it will be good because some doctors don't know how to really talk to us. This is a conversation that I'm going to need to have, and then I'm going to have to tell my husband what it is I want, because there are some things I just don't want. I don't want long suffering. I don't want to be on any machines. I don't want to be without my limbs. I don't want to be without my kidneys. There are things I don't want. And so when you ask the question, how far are you willing to go? Okay, if you become sicker, how much are you going to go through? I don't want to live my life with someone else having to take care of me. And I'll skip over the next one. So just some concluding thoughts. It's more useful to think of health literacy as an emergent phenomenon rather than something that is or is not possessed by one individual. In order for health literacy to emerge in a way that supports advanced care planning and palliative care, we must focus not on advanced directives, even those that are easy to read, but on scalable, translatable communication practices that help patients and clinicians enter an inevitable space together, arm in arm, without fear of ineptitude on the part of the clinicians or abandonment on the part of patients. Conversations that focus on procedures will never be effective on their own with certain populations because they're hard to understand and they prioritize the clinician's goals, not the patient's. And a conversation intervention focused on eliciting goals, priorities, and strengths is understandable, acceptable, and needed for communities for whom these conversations are poor quality, infrequent, and late. Thank you.